Welcome, everybody. We are very excited to have you here for hear about motivational interviewing, something that I talk about quite a bit. And I am really happy that our speaker today agreed to present on it, because I don't know anybody better to talk about motivational interviewing than Russell Spieth. Dr. Spieth comes to us from Cleveland, Ohio. I have known him for, I was just counting, and it's like 14 years, Russell.
Wow.
So he's a former colleague, and currently he's the director of outpatient treatment at a addiction recovery program in Cleveland. So take it away. Questions and answers, please use the Q&A box or the chat. So take it away, Russell.
I will. Thank you so much for having me. And it's always terrifying to second. It's good, right? Yes. Okay. So yeah, we're going to talk about motivational interviewing today and assisted outpatient treatment. Just really quickly, a little bit about me. I've basically worked with people who are mandated to treatment since 1995. Oftentimes I was early on in the drug treatment courts in New York City, drug treatment alternatives to prosecution, treatment alternatives to street crime. And I believe Amy might correct me, but I believe I was the case manager / manager for the first person with serious and persistent mental illness who was involved in assisted outpatient treatment in Ohio.
No, Cleveland.
In Cleveland, okay. Yeah, so I was trying to spread my wings a little further than I should have. So I'm going to try and kind of speak about MI from that perspective, and I will begin to say MI because it's hard for me to get my mouth around motivational interviewing consistently. So what we're going to kind of try and look at is how can MI techniques improve court-ordered treatment outcomes? Just kind of touch on some of the relational and technical aspects underlying MI. And then we will talk about some specific MI skills to help get people to talk themselves into change, but also when you have folks who are in pre-contemplation or saying, basically, I don't want to do what you're telling me to do, some strategies to kind of work with those folks as well. And starting off with definitions, right, like any good presentation, motivational interviewing is evidence-based, and to that point, there's been hundreds and hundreds of randomized clinical trials to this point that have shown MI is more effective than the typical directive approaches. There's been dozens of studies with people with serious and persistent mental illness to suggest that MI is more effective than the typical directive approach. And there's been dozens of studies with people who are court-ordered to treatment in some capacity that have shown MI is more effective than the typical directive approaches. And it's brief. You can do it in a couple of minutes. You can do it in 50 minutes. It's applicable across a wide range of problem areas. So everything from people taking their medications to people going to the treatment center, to people engaging in counseling, to people engaging in other types of health behaviors like stopping smoking, stopping drug use, exercising. And it's learnable by a broad range of helpers. And you all, some of you may know, or may have gone through training. There has been a movement for folks involved in the criminal justice system to learn MI, probation officers, sometimes judges, things of that nature. It's another definition I like is a collaborative conversation style for strengthening a patient's own motivation and commitment to change. So it's a conversation and it's collaborative. So we're going to touch more on that. But and this is, I think it's a philosophical shift sometimes for people, but it is, when we say collaboration, yes, me as a psychologist and me, having a 25-year career or what have you, and being a human being, I have some expertise, right? But every patient I work with, including those that are court-ordered to treatment, also have expertise. And it's really kind of acknowledging that and two people coming together with their expertise to come up with a plan. Another definition is arranging conversations so people talk themselves into change based on their own values and interests. So I'll give you a quick example. Right before I came here, I was at my job, and a lot of our folks are mandated to treatment. And a guy came in and he said, I said, well, what brings you here to this drug treatment program? And he said, well, I have to be here. And I said, well, you don't really have to be here. You chose to be here. And he kind of looked at me weird. And I said, well, what were your choices? He said, well, I could have gone to jail or I could have come here. And I said, okay, so that's a good choice. You chose to come here. And he goes, yeah, I guess what you're saying is right. I said, well, how come you chose to come here? And he said, well, I just want a better quality of life. And I said, well, tell me more. What does better quality of life mean? And then he began to talk about sort of his interest in being more involved in his children's life. He was interested in, he had kind of given up on a welding career earlier. And so as he's talking out the fact, acknowledging that he made a choice, acknowledging and saying out loud that he made a choice to have a better life, and then got specific about what that better life really involved, that's basically MI. It's trying to set up conversations so the person talks themselves into change. The kind of the relational philosophy or underpinnings of MI is this motivational interviewing spirit. And it's those 4 elements: partnership, evocation, compassion, and acceptance. We'll kind of go through those. Partnership collaboration, that's basically what I sort of mentioned earlier, is this 2 experts getting together to discuss a path forward. So I can remember when I was working with the gentleman we were talking about earlier, who was the first AOT patient in Cleveland. There would be many times when he would say things like, I don't want to keep doing this. I don't want to meet. I don't want to take my medications or what have you. And I would say something like, that's your choice. You can choose to do that. What do you think will happen if you do that? And then he would say, well, they're going to be all over me and they're going to put me in the hospital. And I would say, okay, well, kind of what makes more sense to you right now? Does it make more sense for you to take your medications and go to appointments, or does it make more sense for you to not do that and to be hospitalized? And he would generally say, well, I guess, it makes more sense for me to do what y'all are saying. That's kind of an idea, like an example. I wasn't telling him what to do. I wasn't directing him what to do. What I was doing was engaging him in a conversation where he could make a decision that he wanted. And obviously, so if I was working with somebody and I were to say to them, well, what do you think will happen if you don't take your medication or you don't engage in treatment? And they were to say, well, I don't know. I don't think anything will happen. Well, then you can put on your little expert hat and say something like, well, would it be okay if I share with you what will happen? And they would say generally yes. And you would say, well, what will happen is likely you're going to wind up being hospitalized again at some point and not have the freedom that you even have now. And then kind of asking, what do you think about that? So the other part of partnership and collaboration is you educate people in this way that you ask permission generally, and you wonder what they think about your idea. It's a respectful way to work with people. It promotes their dignity, and it helps them feel more a part of the process. And what we know, and if you think about I always ask people when I have more time to think about your own behaviors, and especially your own health behaviors. Most of us don't like it when we go to a provider for our diabetes or hypertension or whatever, and they tell us, you need to start exercising and you need to stop eating that food you love and you really need to start now. We kind of knew that, and many of us kind of recoil from that type of a conversation. But oftentimes we do it with people with mental illness or substance use disorder, and oftentimes they recoil in the same way. So it's really this idea of trying to be more collaborative and partnering with people and engaging in their own expertise. The second element of the MI spirit is acceptance, and that involves, academics always got to come up with, number of facets under each domain. But the parts of acceptance are accurate empathy, which basically means trying to wonder really about the person's experience and to, as best you can, walk in their shoes. And this is where I'll say a really important part of this is that empathy doesn't mean you agree with a person, right? That's not empathy. Empathy means, you may agree with them, But empathy doesn't, you don't have to agree with someone to empathize with them. You just have to try and understand them. And when you're trying to understand a person's behavior, we typically start off in motivational interviewing by wondering, why would the person not want to engage in the services that we're providing? So oftentimes my first conversations with someone will be something like, what are the reasons why you really don't want to take your medication? Tell me some reasons why you don't want to engage in treatment. Tell me some reasons why you think you're better off without being involved with us. And then you actually empathize with them, which can be hard. And you say, okay, I get it. You really enjoy your freedom and you feel like your life was fine before you involved with us. And you really don't like the side effects of medication and you don't believe you have a mental illness. So why would you take medication for it? And you're not only asking why they like the quote unquote problem behavior, but then you're empathizing with it. Obviously, then on the other side, you do wonder, well, what are some reasons why you might want to take medications? What are some reasons why you might want to engage with us? What are some reasons why you might want to attend these appointments? So you typically start off by asking, what does the person like kind of about the status quo, what they've been doing, and what is the person like about the change that you're kind of asking them to do? So a few reasons why you do that. First of all, it's respectful, it's collaborative, and people are more likely to get on board and make changes when you engage folks in that way. Secondly, if you think about it, if you empathize with the reasons why people don't want to change and you respect that, you don't have to agree with it again, but you respect it and you empathize with it. When you ask the other side, what are some reasons why you would want to engage with us? It frees them up to be much more open about what some of the benefits might be. And I see it every single day. You ask people, what do you like about smoking crack? What do you like about drinking alcohol? What do you like about doing things the way that you've been doing them? And then you ask the other side, what don't you like about it? They're much more open to discussing those things with you. So that's kind of about accurate empathy. Absolute worth is just this idea. I always ask people, think about your least favorite type of client. I think we all have our certain types of folks that, for whatever reason, we have a hard time connecting with or sympathizing with or engaging with, whatever those characteristics are. I would ask you to think about that type of person. It takes a little bit of intellectual effort and emotional effort, but to see the good in them, right? And to see the worthiness of them. And oftentimes people do things for a reason. It may not make sense to us, but they do things for a reason. And so having worked with people with serious and persistent mental illness quite a bit, we would know, generally the research suggests they've experienced a significant amount of trauma, right? Just as one example. What do we know about people who experience trauma? We know that oftentimes they're re-experiencing trauma and they have organized their world in such a way as they try very hard to stay safe, even when it may not be adaptive. So I might be working with a particular individual and they might come across as somewhat aggressive or dismissive of me. And it's helpful for me to keep in mind that probably is something that person found adaptive at some point in time. Yes, it's not adaptive now, and we're going to need to work on that, but it's not that they're a bad person. It's that they were sort of socialized to engage in that way. Emphasizing autonomy is really, again, I say this about mandated people all the time. Mandated people have choices, just like every one of us has choices. They can choose to deal with the consequences of not complying. So I really, when I very strongly take that out of my mouth, you have to do this. People generally don't like to be told what they have to do. And by the way, it's not real anyways. It's not realistic. They have to do it in order to perhaps not be hospitalized. They don't have to do it, in general. And so it's recognizing that people have autonomy. They can deal with consequences. They can make choices. And it's acknowledging that to people and saying, you know what, you get to decide what happens from here. You get to decide either that you engage with us and you take medications and you keep your appointments, Or, the alternative is to not to do that, which would lead to being hospitalized. What makes more sense to you at this point? That may sound really weird to say, but I think if you think about other behaviors, we typically like choices. Human beings like choices. And again, it's realistic. People don't have to do anything. The affirmation is trying to catch people being good. That was my son's principal, used that line, and I've stole it from her. I let her know I stole it from her, but catching people being good. And so a lot of times when you're working with people who are court mandated, we are very hyper focused on noticing all the struggles they're having or the ways in which they're not being successful, right? But oftentimes there's just as many or more very positive things that they're doing that we may not notice or minimize. So for example, is even a person showing up for an appointment, remembering again, they don't have to go to the appointment. They could deal with the consequences of not going to the appointment. So I say things like, and this is really genuine because I've gone through significant changes in my life. I know change is hard. I'm in awe of people making changes. So I let them know that. And I'll say like, whoa, I'm so impressed. It's so good to see you here. It says a lot about how much you care about yourself and your freedom or whatever it is that I know about them. Wow, you're really taking steps to be the dad you want to be to your son. Wow, you're really taking steps towards, having this freedom that you really want in your life. Wow, and just acknowledging it as opposed to, okay, they showed up, great, and why we do that, we'll get to it in a moment, but motivation, what we believe, or people who study motivation believe that motivation is really comprised of two factors, importance and confidence. So if I'm going to engage in court-ordered treatment, it's got to be important to me, right? I got to believe that engaging in court-ordered treatment is better than the alternative. That's the important part. But I also have to be confident that I can do it and confident that's going to be worthwhile. And if I'm not really humming on either one of those things, I'm not going to engage in court-ordered treatment to the degree that we would want folks to. So the affirmations get at that confidence piece. And if you think about people with serious and persistent mental illness, I'll just ask you to think a little bit about what are some of the societal stereotypes we have about people with serious and persistent mental illness. I would argue that the stereotypes that jumped into your mind were not on the positive side. They were probably more on the negative, dysfunctional side. What we know is that people oftentimes internalize those stereotypes, and they may not voice it, but they might feel very ineffective as a human being. And because that's what the world's told them for quite a bit. And it's hard to make strides in your life if you feel like an ineffective human being. So I think it's incredibly important, especially with this population, to acknowledge everything positive. And again, including acknowledging, wow, you made a really good decision to be here and do this, as opposed to being hospitalized again. Wow, what led you to make that good decision? Compassion is the third element of the MI spirit. Basically, just, I know we have attorneys on here. We may have some judges. I know we have a psychologist. We have some social workers. Basically, this just means stick to your ethical codes is the compassion piece. MI has been shown to be so effective, and it's been it has been used for reasons that we would argue are unethical. An example would be using MI to motivate a person to engage in a research study, right? That would be unethical. So basically the compassion part is do no harm, just stick to your ethical codes of your particular profession. Evocation is this thing where you're trying to figure out ways to get the patient to talk themselves into change. So again, the guy that I worked with years ago in Cleveland, there was I won't give too many details, but he had a lot of really interesting interests that I knew he could really only pursue if he was not hospitalized. So I oftentimes asked him things like, wow, now that you've been out for a few weeks, like what kind of things are you doing? And he would kind of tell me the kind of things that he was into. He was like a mathematical genius, and he would do all kinds of math work, and he had access to a computer and things like that. And I'd be like, well, you know, what are you learning about with math and what kind of things you've been working on? And like, you know, how's that different than when you were hospitalized? And he would be like, oh, I couldn't even do any of this when I was hospitalized. He was working on formulas and all kinds of stuff. I couldn't do that when I was hospitalized. I say, oh, well, what do you think that means? Well, if I caught him on a good day, he would say, I think that means I need to keep doing this so I can do the things I enjoy. So, you know, and this is where I'd also say, you really, you know, you want to know, what does the person ultimately want in their life, and how does engaging in court-ordered treatment relate to that? You know, like what are they hoping to get in their life? How does being hospitalized interfere with that? You know, another example with that would be something like, in a very neutral way. And when you're doing MI, it's very neutral. You really are like interviewing, like you're an interviewer on TV interviewing somebody in a neutral way. And it's something like, well, you know, I know that like your relationship with your daughter is really important to you, and I know you were saying that you really want to be there for the school year for her. Like, what do you think it would be like if you were hospitalized during the year? How would that affect that relationship? And then you want the patient to say out loud, I would hate it because I couldn't go to see her this or that or the other. That's that person talking themselves into change. A lot of times as experts, we say things like, well, you know, that's going to mess up your relationship if you don't comply. You just stole that from that person. What we want is for the person to say that out loud. And again, I think most of us are more persuaded by our own talking points than by other people's. Things that you're trying to avoid when you're doing MI is persuading people without permission. So all this kind of like, yeah, but I really think you need to do this, and yeah, you need to do it, and I'm really encouraging you to do it, and da 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 da. People oftentimes recoil from that. Again, I will oftentimes say, hey, would it be okay if I share with you what I think you should do? And people always say, what happens if people say no? Well, first of all, it's the patient's right to say no. The only thing they have to agree to listen to is an informed consent, or you know, on the legal side, like legal type of stuff. The legal people can say it more eloquently than me. But on the clinical side, the only thing they have to hear about is the informed consent. Everything else, they have the absolute right not to listen to. So I would never ask permission to educate people about the informed consent, but I almost always ask people for permission to educate them about something. And people say, well, what if they say no? And I would say, I've probably done this. I've probably asked that question, I don't know, it's hundreds, maybe 1,000 times. I have never heard anybody say no yet, ever. And people generally are, including people with serious and persistent mental illness, they sit up in their chair a little bit more. Because again, I'm treating them with respect and dignity. I'm not assuming they want to be educated by me about something. Confronting people, you know, I mean, confrontation generally just increases the confrontation from the other person. So it generally leads to conflict. Having a premature focus, like if I really think the person needs to pursue this course, the person may not buy that, but maybe they're willing to kind of engage in some other course. And if you had the opportunity to do that and that fit within your scope. So an example would be maybe someone who we believe they needed to do a long-lasting injectable antipsychotic medication. They're afraid of needles. You've all probably heard people say all kinds of things about being injected, but maybe they're willing to try with orals. You know, it depends obviously on the person, the situation, but you know, in the MI world, sometimes you maybe start with the orals first. If it doesn't work, you can always go to the injections, right? Labeling people, I always joke about this. If labels were so important, why does the diagnostics and statistical manual change the labels all the time? And you know, basically experts get in the room and argue for years about like, well, does schizophrenia exist? And if so, is it one disorder? Does depression exist? If so, is it one disorder? And there's always arguments about whether these labels exist or not, and they change over time. So I'm much more interested in having a person discuss symptoms. And if they don't endorse having the label of schizophrenia or what have you, no harm, no foul, as long as we can agree on symptoms. And sometimes you can't even do that, right? But that's more where I'm shooting for than like that they acknowledge that they have schizophrenia. Blaming, shaming people, and educating without listening. So those are some of the things that we oftentimes do, but that really the research suggests overwhelmingly, if you believe research, you would kind of take home the idea that this is way less effective in general than having a more collaborative, empathetic, evocative approach with folks. So what are some of the principles and strategies of MI? Developing discrepancy, role with resistance, boosting self-advocacy, and expressing empathy. So developing discrepancy is, again, so I ask people questions like, you know, if our work together went pretty well, what would be different for you in 3 months, 6 months, 9 months? And then listen intently to what that person says. It's like my guy earlier today who wants to be a welder. And I don't just sit on, oh, you want to be a welder. I say, how come? How come welding? What would you want to do with welding? And, you know, because of the kind of the motivations in the story. And so he talked a lot about how much he enjoyed welding. It was meditative to him. He got, it was one of the only things he ever got positive feedback about in his life, right? So for him to say all that out loud, that's making that goal much more realistic. And then I dropped in the, well, you know, how do you think completing treatment here would help you get to that goal of being a welder? Well, basically, I got to stay sober. I'm never going to get a job, and I can't pass a drug test, and da 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 da. So, you know, it's kind of like helping people see and talk out loud about how engagement in treatment is going to help them lead to their goals, and not engagement in treatment. So in your realm, being hospitalized is probably not going to be in line with their goals. Now, I know some of you are thinking, well, some patients want to be hospitalized, and that's a challenge. And then you know, that you may not be able to use that discrepancy for that person. And that does happen occasionally. You have the people who seem more comfortable being hospitalized. And there's some other things we can talk about that. With psychosis in particular, sometimes you have to ask really concrete questions. There's also a values card sort that I'm going to show you in a minute that I used a lot with people with schizophrenia spectrum disorders, where it's kind of a list of values and they sort them into what's very important, kind of important, and not at all important. And you kind of use that as a way of helping them think about what do they really care about in life. So these are some questions that, you know, you kind of help get goals and values. What do you care about in life? What are the rules you live by? What are the things you admire about people? What does healthy, doing well mean to you? How come you chose court-ordered treatment over incarceration/hospitalization? I know in your realm, it's not really incarceration, so it's more hospitalization. In my realm, it's a lot of times incarceration. But nonetheless, just kind of wondering how come they chose that. Like I mentioned, there's a link there at guilford.com of this values card sort. And again, especially for people with more negative symptoms of schizophrenia, or just folks who are less talkative or relational in the typical talking kind of a way, I found values card sorts to be really helpful. Just another idea, artwork. There's a lot of research to suggest, and I've used it a lot with people with schizophrenia spectrum disorders. Again, those who are not as verbal, where I would ask them to make collages of what they want their life to look like. Boy, you get some really interesting stuff then. And then you ask them as much as they can to kind of talk about it. And then the same thing, like you then wonder, I can remember a guy doing that, and he had all these pictures of people with like mortar boards and people with books and things like that. I was asking, you know, well, what does it mean? Like, what are you hoping your life looks like? And he kind of talked more than I ever heard him talk about how he wanted to get his GED and how he had to give up on his education earlier in his life. So then his conversation's like, well, you know, how do you think taking medications helps you with that goal? How do you think engaging in treatment helps you with that goal? What's it, you know, when you weren't taking your medications, how much were you thinking about education? You know, those kind of things. This is where I'd also say, patience, right? Like, I mean, people sometimes take a little while to change, right? And again, I do always, the audiences I'm talking to, I like for them to consider their own health behaviors. And yes, we can all argue that, well, if I don't engage in my health behavior, I'm not going to be hospitalized. Yeah, maybe so for some of us and all that, but nonetheless, probably everybody on here is engaging in some behaviors that are not as healthy. I'll just acknowledge the fact that I eat way too much meat, right? And I would probably be better if I had more of a plant-based diet. I've known that for years. I've tried to work on it for years. I'm from the South. I like meat. So, you know, it's, you know, like it can take people a little bit to make changes. And sometimes we need to be patient with that. Again, within the confines of the civil commitment. Rolling with resistance is basically just this idea that when a person is saying, I don't want to do what you're telling me to do, I don't want to take those medications, I do not want to deal with y'all, you can, in a very respectful way, empathize with that and say something like, okay, I get it. You want nothing to do with this, and you're open to the consequences of that, or you're open to that leading to hospitalization. You can do it in a very respectful, dignified way. This is where I will acknowledge to you all, I'm in recovery from substance use disorders, and the clinician that had the most impact on me basically did just that and said, hey, yeah, you know what, you get to decide what you do from here. And it was a pretty profound thing, and it was kind of interesting to me that no one had ever said that to me. And it did lead me to kind of think about, okay, yeah, it is in my control, and I do have, I can decide what course I go on. I can deal with the consequences, or I can deal with the consequences of recovery, or the consequences of not recovery. Boosting self-advocacy, again, this is a big thing, which we talked about. When you think about severe and persistent mental illness, I think about stigma, and stigma basically taps, whatever word you want to say, people's confidence. So some of the things that we do to help boost people's confidence, and the research suggests all of these are ways to help people boost confidence, is affirming past and present successes. So again, if a person comes to an appointment, I'm gonna acknowledge and celebrate that. If a person reports taking medication, I'm gonna acknowledge and celebrate that. Settings, when you can, again, you have to work within your confines, but I really like to work with people around setting small goals. So with the person we were talking about earlier, there was this period where he was taking medications every other day for a little while. And because that's what he was willing to do at that point in time. He thought he could do it. The psychiatrist who was working with him felt like, yeah, it's not optimal, but it's something, right? And so we agreed to try it. And lo and behold, like most of us who do small things and get success from it, it wound up leading him to be more inclined to take medications as prescribed. Again, sometimes you can't do that based on, you know, whatever the elements of the civil commitment are. But when you can, it's helpful. Because again, I want you to think about yourself. Like, did you make changes dramatically overnight? Probably not. Maybe you did. And if you did, you should be teaching me how you did that. Eliciting past successes. So I ask people a lot of times, like, okay, this seems really hard. I get that. Tell me about another time in your life you overcame something that you didn't think you could. Boy, you can hear some really interesting stuff there. And really, ultimately, making changes in one area of your life, there's oftentimes a lot of transferable stuff to making changes in other parts of your life. Because typically when we make changes, we need to do a few things. We need to know how to ask for help. We need to be patient with ourselves. We need to try a little bit every day. And we need to deal with the distress that's associated with making changes. So if you ever made a change in your life, you've got those elements probably on board. I ask people a lot about role models. The research is pretty clear on this. People are much more likely to think something is possible if they identify with someone who they've seen make that change. So, you know, why a lot in the psychiatry realm, it's educating patients about some of the brilliant, amazing, successful people we have in society who are diagnosed with schizophrenia or other schizophrenia spectrum disorders. Maybe they know people in their own life who have been taking mental health medications. So I say things like, first of all, I may do some education around, hey, did you know, like whatever their diagnosis is, hey, did you know that these people were diagnosed with that same issue? and then kind of have a conversation about it. But then I may also ask them, you know, anybody from like your area you identify with that you've known takes mental health medications? Okay, well, like, what do you think about that? And like, would you be open to talking to them about that? And, you know, and then setbacks or relapses or learning experiences. So it's kind of this idea of like, okay, so that didn't work. What did we learn from that? What do you think you need to do going forward? How can I help you going forward? Expressing empathy, we're going to get more into this in a minute, so I'm going to kind of breeze through it. But it's these statements that you make towards people that it expresses that you understand what's going on with them. And that's what we're going to call those reflective listening and summaries, which we're going to get to right now. So open-ended questions. I'd say one of the most famous closed questions we ask people are, have you been taking your medications? And they say yes or no. And we didn't learn a lot from that question because we don't know if they took them as prescribed. We don't know how they think about it. We don't know anything. And plus, asking people a yes or no question, they're much more likely to, let's just say, not reveal the truth. So I typically ask people things like, hey, how's it going with the medication? Or even better, because what we know, the research suggests people with serious and persistent mental illness, especially schizophrenia spectrum disorders, are well below half, is they're less than 50% are taking medications as prescribed. So why don't I ask a question that builds that into my question and say, hey, I'm wondering what kind of issues, problems, barriers, obstacles you're having with taking your medication. You've done a few things when you ask the question that way. You have greased the wheels for them to be much more honest with you, perhaps, because you've already built into the question what problems, issues. And guess what? If they say no problems, working great, I love it, you get to affirm them. Wow, you really care about your health. You're making this change really good. That's incredible. And if they don't, then you may get a much more honest answer, right? Affirmations, again, that's catching people being good. I really challenge you to think about the folks that you're working with and think about what are some opportunities I'm missing where I could reinforce some of the small successes they're having. And even, you know, I was talking about the open-ended question about taking medications. If a person says, yeah, you know, I've been having a hard time with it, I don't like the side effects, I've been taking them every other day, as an example, you could affirm that honesty. And I would say something like, whoa, that takes a lot of courage to say that. I appreciate that. That's very honest. That doesn't mean that I still might not, after that, say, well, hey, well, what do you think will happen if you keep not taking your medications, right? You can still go down that road. But in that moment, like, you can affirm their honesty, right? They just did something they didn't have to do. And I like to reinforce people being honest and courageous. Reflective listening, we'll go to that in a minute. Summaries is basically kind of like a long statement that is also a long empathetic statement, which we'll get to in a moment. And informing with permission is what I discussed at the beginning, where when you want to educate somebody, you ask permission to educate them, and then you wonder what they think about it. So reflective listening is listening to language accurately, forming a reasonable guess as to what's being communicated, and giving voice to that in the form of a statement. So it's not parroting people, because people generally don't like that. They're like, whoa, okay, you get paid all that money just to say what I just said. It's really trying to think deeper about what they're saying. So for example, a patient may say, oh, this treatment's ridiculous. I might think what they're really saying is that they thought they were fine on their own. And so I may say, you believe that you were better on your own, or you were fine on your own. And again, this is where I'd say you can empathize and not agree. And it doesn't mean you can't educate in a little bit, but you empathize with that statement. I also might think that person might be a person who really likes to have more control. So I may say, you prefer to have more control. What business does anybody have telling me to take my med? That's another thing someone might say. And you may say something again like, you really respect, you really like to have privacy, or, you know, it feels undignified to have so many people in your business, or, you know, you feel like you can take control of your healthcare just fine, right? It's different like statements that kind of get at a different angle of what the person's saying. Person says, you know, or you ask, how's it going with the medication? Person says, I don't think it's good, I think slower. I might be thinking at that point that they are dissatisfied. So I may say, you're really dissatisfied with the medication, or you're disappointed the medication's not helping more, or you're kind of like not sure if you want to keep taking the medication, right? So it's, again, these empathetic statements that are kind of taking a guess at the deeper meaning that the client's saying. And again, I know I've said this like 4 times now, but it's so hard for people to understand that you can express empathy in the form of a statement and not agree with the person. And again, it doesn't mean that you don't do that and then further on say, well, what do you think will happen if you keep not taking your medication? And what's happened in the past when you weren't taking your medication, But in that moment, and there's something about reflections that the research suggests, empathizing in that kind of overt way is almost like the secret sauce of the change. The more people do that as a clinician or, again, probation officers and such, the more patients actually change. So these are some strategies to evoke change talk, where they're highlighted in, I forgot to say about the summary. The summary is a long reflection, and you kind of summarize all the reasons why the person is ambivalent. So an example of that might be something like, okay, on the one, and you start with the reason why they don't want to change, and you end on the reason why they might want to. So I would maybe say something like, okay, on the one hand, you don't want to take these medications because, first of all, you believe you're fine and you don't need medication. And secondly, when you've taken it, you didn't feel yourself, and you didn't feel safe on the street because you didn't feel like you were alert enough. And thirdly, you're concerned about weight gain and some of the other issues associated with it. Okay. And on the other hand, you're thinking that maybe you will take medication because, the past 10 years, people keep telling you that you're better off when you're taking medications. And secondly, you do understand that if you don't take these medications ongoing, it could lead you to be hospitalized again. And you don't want that because you really want to be there this year for your daughter because you know that school is important for her this year. So that's kind of like an example of a summary. It's a long reflection where you start summarizing the reasons why they don't want to change. You end on the reasons why they do want to change. And then typically that kind of emphasizing autonomy thing, you ask, what do you think you're going to do? Because ultimately they do get to decide what they're going to do. So evocative questions, we'll get to those in a minute, the ones in light blue, but basically those are desire, ability, reason, need questions. Elaboration. So I've kind of alluded to that earlier. If I'm going to be motivated to make a change, I need to tell my story. Everybody's got their own story. So, like the guy I was talking about earlier with the mathematics, like I didn't just kind of be like, oh, you like math? That's cool. Like what, that's not really anything. But to ask him, like I didn't understand what he was talking about because I'm okay at math, but it's not my strong suit. But nonetheless, I tried, and I was just kind of asking him for details and like, what does it feel like when you're doing math? And like, what does it mean to you? And what are you hoping to solve? Right? Because that's what's going to inspire him. And he likes to do that, and being hospitalized interferes with that. So the more I can get him to talk on it, the better. Examples. So an example of an example would be a person saying, I can't stand being in the hospital. It really sucks, and the food's really awful. And I'd say, well, give me some more examples of why you don't like being in the hospital, right? And have them kind of talk that out loud. Again, the story is where the power is. Human beings are storytellers in general. Even if it's not verbal, again, it can be through art. And the story is what's going to be motivating, not just, I don't like the hospital. Well, how come? Tell me more about why you don't like the hospital. Decisional balance, we talked about that earlier. You typically ask on the front side, what do you like about not taking medications? And then on the other side, what might you like about taking medications? Looking back, you may ask things like, tell me about a time in your life when you felt like things were really a lot better for you. You weren't in the hospital and there weren't all these people on your back. What were you doing? What was going on at that point? It's interesting. Sometimes people kind of forget that they had good experiences and they forget what they were doing. And it's not uncommon for even a person who doesn't like to take medication to recall that, well, it's kind of weird, but things were better when I was taking medication, and I had a lot less people in my business when I was taking medication. Looking forward, I've mentioned that earlier. That's those kind of questions like, if our work together went pretty well, what would you be doing in 3 months from now, 4 months from now? These query extremes, that's when you ask folks something like, what's the worst thing that happens if you don't engage in this treatment protocol? What's the worst thing that happens if you don't? What's the best thing that happens if you do? Again, obviously what you're trying to do is to get that person to tell their story of why it might be important. Importance and confidence rulers, that's in blue, so we're going to look at those in a moment. And sometimes just exploring goals and values in and of itself is inspiring to people. Again, I would challenge you all to think about the degree to which right now you're living in perfect concert with your goals and values. Probably none of us are, right? Our goals and values are somewhat aspirational normally. But sometimes just thinking about like, well, what would I really, want to be doing, or what do I really value and how much am I doing it? Sometimes just thinking about that and that discrepancy motivates us to make some subtle changes. So these are those darn questions I referred to. Desire is like a want. Why might you want to take medication? Ability. If you were to kind of get on a medication regimen, how would you do it? What would be helpful for you to do it? Reason. Give me 1 or 2 good reasons why you should take your medications. Need. How come it's important for you to take your medications? Those are obviously different facets of motivation, right? There's desire, want. There's reason, is like a rationale. Ability is kind of like the confidence piece, and need, the important. So it's just different ways of getting the person to talk themselves into change. I use these all the time with all kinds of populations I work with. I find it really helpful for a few reasons. First of all, it does evoke change talk. Secondly, it helps you understand where's the person stuck. Is it importance or confidence? So something like when you're considering your goals and values of, I can't see this, being in your son's life, on a scale of 0 to 10, how important is it for you to attend your psychiatric appointments? And they may say a 2. And you say, well, how come you're a 2 and not a 0, or a 2 and not a 1? And you ask a lower number because that's going to evoke whatever little reason is they want to change. No, they may give you a 0. And at that point, you just, again, that's like the rolling with resistance. Okay, I get it. That's not important for you to do right now. And you're open to the consequences. And then you may ask on the other side, what would it take for you to be at a higher number? What would it take from you to go from a 3 to a 5, right? So it kind of gives you a sense of, first of all, helping to understand where they're stuck in terms of importance, and helping to get them to talk themselves into change. Confidence is, like we mentioned, the other element of motivation. So on a scale of 0 to 10, how confident are you that you could take your medications every day as prescribed for a week? And again, same thing. How come you're a 3 and not a 1? And they can talk about whatever reason they are confident. And what would it take for you to be from a 3 to a 5? So when people don't want to change, so they're telling you, I don't want what you're trying to get me to do. I don't want to deal with it. There's a few things. These are really hard. I'll acknowledge this. It's not intellectually hard. It's emotionally hard. Making no moral judgments about people's behavior, respecting the patient's right to self-determination. They can choose to receive consequences of not adhering to programming. That's their right. They have the right not to adhere, and they have the right to, the kind of the human right to deal with consequences of that. We can't make people do anything. Recognize that you have no control over patients' behavior. We can influence it to some degree. And again, we could think about the worst case scenario, which I hate to bring up, but we should. This population is significantly more likely to die by suicide than other people, right? I hate to even bring it up, but like a person could choose, I don't want to engage in treatment and I'm going to die by suicide, right? I think that's just an example of how we really can't control people's behavior. And appreciating you, first of all, most of us can't even fix ourselves. So, and I'm meaning like, like drinking too much soda or whatever. So it's really kind of like delusional to think that we can really fix other people. We can certainly influence people, but fixing people is really not our responsibility, nor can we really actually do it. So you empathize with sustained talk. So I'm done being in treatment. It just isn't going to happen. You can use kind of like an amplified reflection, which is this kind of like really strong, almost kind of like black and white reflection. So you much prefer inpatient treatment over outpatient, right? That would be a way of saying kind of more intensely what they're saying. Coming alongside, it's a little softer than that. You feel discouraged. Emphasizing personal choice. You can choose not to take medication. And when you've made that decision in the past, you ended up in the hospital. Again, you would say that, or I would say it, and MI folks would say it without tone in their voice. So it wouldn't be like, all right, well, yeah, you can choose not to take medication. And yeah, well, we know when you made that decision in the past, you ended up in the hospital. People like that, the attitude they're probably not going to love. So it really is even keeled. And actually, I have to take a deep breath sometimes when I say things like this, not too overtly. I try and do it discreetly, but you can choose not to take medication. And it seems like when you made that decision in the past, you ended up in the hospital, and then just kind of seeing what they say. So am I planning? So like almost every other change behavior out there in the world, the best practice is ultimately developing a SMART goal. This happens in the professional world. Many of you probably at your work do SMART goals, and it happens in the clinical world. And so, ultimately you're trying to kind of end on some kind of SMART goal. So specific, what's to be accomplished. So the person's going to take their psychotropic medication. Measurable. They take the psychotropic medication as prescribed every day for a week. You could measure that. You could do blood draws or whatever, but you could in a qualitative or quantitative way know that that was happening. Achievable. The person believes they can do that. Again, that idea of helping people identify small goals that are appropriate, and then building from there. So a lot of times I ask people things like, okay, that seems like too much, too big of a change. What do you think that you could do that's possible that moves you in the direction of some change? Relevant, the goals align with the person's preferences, goals, and values. So person believes that taking medication is better than the consequences of non-adherence because they value their freedom. So it's relevant. Taking medications equals freedom, and they like that. Time. So over the next 7 days, client will take psychotropic medication as prescribed. So that's kind of an example of a SMART goal. And these are my references, and I will stop sharing now and see what, if any, questions we have.
So the first question is, what therapeutic approach does MI work best with? I have heard other professionals say they use MI with CBT. Can you use MI on its own without a specific therapeutic approach?
Oh, that's a good question. That's a good question. Yeah, MI is a really interesting intervention because it can be a standalone intervention. It can, this could sound wild, but I had a guy years ago with serious and persistent mental illness, and he wasn't an assisted outpatient treatment, but he didn't want to take medications, and what he believed his healing process was going to be was through becoming more of a musician again. So I worked with him on that, and he got to the point where he was beginning to do stand-up, like little things like doing some stand-up guitar playing, and lo and behold, he felt better. It didn't cure everything, of course not, but it helped him. It helped his quality of life, and it helped him engage in treatment more because we were respecting that goal. That's an example of MI as a standalone intervention, right? There's not an evidence-based practice of being a musician to treat schizophrenia, right? But he had some innate understanding that might be helpful to him. But it can also, MI can definitely be used. So for example, for medication adherence, so, coupling MI with antipsychotic medication, that's a bundle that has been shown to be effective for reducing symptoms, right? It does work with CBT. MI, because CBT is a very active treatment, like as active in an expert focus. When you're the clinician doing CBT, you're doing a lot of teaching people and instructing people. So MI is seen as like a really nice way to kind of segue into CBT, right? So it may come first and kind of then complement CBT going forward. It's generally been shown to be effective with all kinds of different treatments. I mean, literally, physical therapy, dental hygiene, DBT, supported employment. Again, I mentioned medication adherence, PTSD treatment, like exposure therapies and things like that. So it's a really cool intervention because it can be standalone, and it's shown to be a complement to lots of other treatments, because if you think about it, to engage in treatment, you have to be motivated, right? And so the MI is the motivation part. Great question.
So a family member, a mom, says that her son, she'll say to her son, if you choose not to take your medication, it seems like in the past you ended up in the hospital. His response is always, that's because you are all worrywarts and wouldn't let me just work through my problems.
Mm-hmm.
And see how dangerous and out of control the situation gets.
Mm-hmm. Yeah. So there's a few things about family members, first of all. So the research with family members doing MI is mixed at best, to be completely genuine. I think it's hard because, like I was mentioning before, that if you're doing MI, you have to be somewhat emotionally neutral when you're talking to people. And that's really hard when it's your family member, to be emotionally neutral with them. It is possible, and that's why it's mixed. Some people can do it, and some people can do it for certain issues. But that being said, I think, as a parent or family member, you could still use a lot of MI techniques. So in that scenario you're describing, I think it's maybe when the opportunities are right, is to say, hey, would it be okay if I share with you why we call the police sometimes to have you hospitalized? And kind of pick your opportunity. The person likely will say yes, and then you sort of say, we get scared, and these are some of the things that we notice, and these are some of the things that we see, and we worry about us, we worry about your well-being. What do you think about that I just said? And that might be one of those opportunities to help him see how you're perceiving him. And then, I think your approach, though, what you said is right on, is saying, how come you think that not taking medications leads to the hospital and goes because of y'all? And say, yeah, we've had that discussion, and that is what we'll continue to do, and so based on that, what do you want to do at this point, right? And so I think you're right on. Is just, being patient with him, continuing that process you're on. I know we're at time. Anything, one last one, or are we good?
I don't see any other questions.
Okay. Well, it's right on. There was actually a minute after. Well, thank you all so much for having me, and hopefully this was a little bit helpful. And I'm gonna end on an MI thing. You all will decide whether or not this intervention makes sense to you, and whether or not you think it's helpful.
Thank you, Russell.
Some great stuff. Thank you so much.
Yeah, thank y'all.
Appreciate it. Take care. Bye-bye.